Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 30th Virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. We are recording this evening's presentation so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it on either the IBJI or NSYMCA websites. Dr. Amy Ptaszek will be hosting tonight's program entitled Ankle Instability, Symptoms, Causes, and Treatments. Do you ever feel like your ankle is ready to give way? Have you ever tried to take a step and felt like your ankle wouldn't support you? Have you ever thought you sprained your ankle but just ignored it, hoping the instability and pain would go away? Ankle instability is caused by weakened ligaments surrounding ankle bones. Ankle sprains are very common, and most people think they will heal on their own. However, tonight Dr. Ptaszek will explain the importance of receiving proper diagnosis and treatment of your ankle pain and instability to help you achieve optimal ankle health. Amy Jo Ptaszek, MD, is a board-certified orthopedic surgeon specializing in treating foot and ankle disorders. As a published research professional with immeasurable knowledge in foot health, particularly regarding the impact of footwear, Dr. Ptaszek brings a wealth of expertise to her patients. Dr. Ptaszek is skilled in arthroscopic surgical techniques that are known to minimize incisions and the amount of tissue that must be cut. When it comes to providing care, Dr. Ptaszek always begins by exploring the most conservative treatment options before suggesting anything more invasive. She takes the time and effort necessary to make sure she fully understands the expectations of each of her patients. I know what it's like to be injured and recover, says Dr. Ptaszek. Therefore, I try to help my patients make the best decisions about how to proceed. Stressing the importance of patient empowerment, she ensures that each of her patients understands their particular condition, the recommended treatment plan, the impact said treatment will play in their lives, both professionally and personally, and the subsequent rehabilitation process that will be required. Dr. Ptaszek emphasizes early rehabilitation to minimize time in a cast or a splint. In addition to treating patients through IBJI, Dr. Ptaszek is a senior attending staff member of the Department of Orthopedic Surgery with NUHS and the senior clinician educator plus a clinical assistant professor of orthopedics at the University of Chicago's Pritzker School of Medicine. Her many accomplishments include having been a major in the United States Air Force, where she took care of elite paratroopers, many border national trauma patients, and shared call duties with the Army Medical Center and the San Antonio Trauma Center. She has worked on numerous research projects and publications and has been appointed to several medical institutions and instructed hundreds of physicians. On top of all that, Dr. Ptaszek has collaborated with athletic trainers to design a patented soccer cleat for a more structured fit in order to prevent Achilles tendinopathy. Dr. Ptaszek is a Chicago area native, with a passion for youth sports. She serves as an associate team doctor for high school sports. She provides Glenbrook North and other high school sporting teams with foot and ankle care. She says, living and working in the community is a privilege for all of us IBJI physicians because we see our patients at the grocery store, at high school events, etc. So we all feel this camaraderie about taking care of our people here, which is important, and we're proud of that. I say, thank you for your service, Dr. Ptaszek, on many levels, and what a privilege it is for all of us tonight to have such a committed physician and caring individual educating us about how to take better care of our feet and ankles. During Dr. Ptaszek's presentation this evening, you might find that you have questions, which she will be happy to address at the end of the program. When you have questions for her, simply type them into the question section on your screen, and I will receive them and relay your questions to her. I ask that you please keep your questions general this evening, as Dr. Ptaszek will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Ptaszek via one of the options listed on the slide, which we are showing now, and we will again be showing during the Q&A portion of the evening. One last thing before I turn the evening over to Dr. Ptaszek. I invite you to mark your calendars for Wednesday, August 31st at 7 p.m. for our next IBJI and NSYMCA Education Series program hosted by Dr. Anthony Savino entitled Neurological Health. improving brain health in adults and athletes. Thank you again for joining us this evening, and thank you, Dr. Amy Ptaszek, for your time and effort in putting together this program to help us understand more about ankle instability and the various symptoms, causes, and treatment options available to us. Now, Dr. Ptaszek, please take it from here.
I will, and I want to thank you for that lengthy, weighty, generous introduction. I wish my mother was still around to hear that.
Aww.
Or my family. Thank you. Okay, here we go.
All right.
Sprains, strains, instability. I want to preface my following comments in the following manner. The slides are kind of wordy. They'll be a bit busy. And I just want to make sure that you don't feel like you're missing anything. So several times I'll be repetitive and get back to things. And if there's certain things in the question box that you wish to for me to elaborate on, I can do that. Okay. And I've kind of erred on being a slightly more technical and a little bit extra knowledge in words, because you are knowledgeable people. You read about these things and many different social sources and hear about them news, et cetera, and friends. So you are probably way more knowledgeable about anatomy and treatments than you might realize. So from here out, here we go. So these are our objectives. We're going to evaluate and make a diagnosis of ankle sprain, strain, instability. We'll talk a lot about conservative treatment, some surgical treatment at the end. And then I'm not going to talk often or to any length about inner ankle issues. That's a really much broader topic. So El Clasico. So I'm a big soccer fanatic, and the El Clasico in Europe is Atletico Madrid versus Real Madrid, inter-city rivals. But the classic ankle injury, the classic that almost all of us, to the exception of myself, has endured, is this weight of your body through your leg and ankle and then inverting or turning in your foot underneath your ankle. Ouch. So ankle sprains, just a general commentary about that something's not broken, it's sprained, it's swollen, it hurts, account for about 50% of all lower extremity injuries. The greatest instance are in our basketball student athletes, so the high school, collegiate folks, junior high, etc. And really nearly half of the patients we see in our walk-in clinics, I know you're familiar and bombarded with OrthoAccess ads, etc., open 7 days a week, Monday through Sunday, they have foot and ankle injuries. Thus, I spend some time there. So again, hoopers, predominantly, these are our local kids playing sports. Many of them will have these injuries, and we won't even record all of them because they'll be taken care of by trainers, etc. And the trainers in our school systems here, our tax scholars play for great, great trainers. And just as a sidebar, if any of you have youth that are involved in high school sports here, don't hesitate to utilize the trainers as a source for some PT at school. It can save them a lot of time and you driving them places. So the mechanism is generally an inversion injury, which was what I demonstrated on the El Clasico picture. Weight of the leg. Now, the ligaments that are involved on the outside part of the ankle include this ATFL, anterior talofib ligament, and CFL. Those are the two major players in ligamentous injuries, calcaneofibular ligament. And the ATFL is the weakest, okay? We know that once these ankle ligaments, these two in particular, get stretched, or you have an injury and it's inappropriately rehabilitated or under-rehabilitated, which I often encounter even years past injury, it leaves the tendons on the outside part and the inside part, in addition to your Achilles and bone, vulnerable to some trauma at a later time. Now, the eversion is the whiplash kind of injury, and that's the opposite motion where the foot would be forced to the outer aspect of the leg. And again, we're not going to elaborate on that too much, but that's bad when you have both. So these are just some basics. What do you do if you have an inversion injury, roll your ankle? The first thing is, stop your activity, right? Don't try to continue, just go sit down. Most of us are not paid athletes. We're doing it for pleasure. We're involved in a team. Yeah, you don't want to let your teammates down, but sit down, take yourself out of the action, get some ice on it right away. And subsequently, you're going to be icing your ankle quite a bit. Elevate your leg. Hopefully someone's around that could give you a few ibuprofen if you're not allergic, or just Tylenol. So then you want to say, all right, how bad is this? Do I need to seek attention right away? Can I wait on this? Is this the same old injury I've had in the past? So generally speaking, after you sit for a bit, you can make a casual assumption of the damage by trying to put some weight down. Can you lower your leg, or are you just like, whoa, this is too much, getting that nauseated feeling like this is really bad? So, wait it out a little longer. If you really can't walk, can't put any pressure down, that's a little more serious. And it might not mean that it's broken, it just might mean that it's severely sprained. But one of the big things does it hurting on both sides of your ankle? Again, that's like a kind of a really step up injury to this coup contra coup, and that can also mean that either there's more serious damage, again, maybe not broken, but your heightened attention should be warranted. So if you look down at your leg and there's a gross deformity, the foot's pointing one way that it shouldn't, your ankle's turned awkwardly than the other, and you can't kind of move it, you should seek more immediate attention in an emergency room setting, because it could be a fracture dislocation. That happens. But if it's not, and again, you've gone through the checklist that I outlined in the previous slide, you can seek evaluation on a non-urgent basis, which means, if it's later on that day, if it's an early evening clinic kind of thing, or the next day, that will be plenty. Now, also, if you don't have anybody to help you out, you don't have a splint at home, you don't have a brace at home or anything, then yeah, you might want to come in sooner than later, meaning that day. All right, so this is the classic picture of a lateral ankle sprain, right? This is the outside of the foot and ankle. You can see there's the fifth toe. This is the distal fibula. You can see some veins there. And then the purple is from the blood, which is emanated from around the ankle. Now you say, well, why does it get black and blue? Well, one is because the tissue is traumatized, it's stretched or partially torn, and it can tear into the subcutaneous tissue, and this is where this levels out. That's why we get ice on it right away. So when you come in to visit with an orthopedic surgeon or a physician assistant or an immediate care practitioner, whoever it might be, or the trainer, what should they be doing? Well, if they're at a full center clinic, I'll just plug us again, which we offer. Someone will take your history, you'll review it with the trainer or physician's going to take care of you, and then they're going to go through an exam and look at you, make sure the skin's intact. Hopefully you don't have a laceration or anything open, and then in all likelihood get an x-ray. In the past we used to say, well, if you can walk, it's not broken. That's not always the case, and most patients and athletes feel better if they know there is or isn't a fracture. It's just kind of a nice groundwork, and it's quick. It's all digital now, so we can do that. At that time, we may offer you some form of mobilization, which would be like a brace or a boot or crutches to get around. And what we want to do, especially with the boots, is to help you move and go and do. Because the last thing we want you to do is on your couch, just laying around with your foot in this boot, and then have a setup for, if you're vulnerable or if you're a little, over age 20 or so, a lower extremity blood clot. So even a lot of folks I know who may be immobilized for longer periods of time, I ask them to take a baby aspirin every day while they're in the boot. And then the usual resting, icing, elevating, compression, that's the rice, okay? When you're able to walk, generally physical therapy is introduced. Sometimes we get therapy involved a little bit earlier if you're very sensitive. If we can't get the swelling under control, you'll receive some direction for a follow-up appointment, because the person you see originally may or may not be a foot and ankle subspecialist. And frankly, you don't always have to see the subspecialist. Most people can handle this pretty well, but we're available. And then when you see the next practitioner for follow-up, we know you're probably going to be feeling a lot better, and we can talk about whether or not further imaging like an MRI scan or ultrasound or CT scan is relevant. But generally, the first staging ground is going to be, how bad is it? how bad is it? Is it broken? Do we need a CT scan to elucidate some of the nuances of that? Or is it seemingly going to be more of a routine or ankle sprain? These are just some Frank Netter pictures. I kind of learned a lot of anatomy with Frank Netter. That's his initials down here. This is the outer aspect of the ankle. Again, I'm not focusing a lot on the inner aspect because it's a little more complicated. We could talk about that at a different date. This is the fibula, the smaller bone of the two in your ankle. These are the peroneal tendons. So we remember this with an acronym, short guys in front. So the peroneus brevis, the shorter one, inserts at the base of the fifth metatarsal. And that's an area where, when we do an x-ray, we do ankle x-ray or foot x-ray, we're checking to see if this bone has fractured from the tendon pulling, trying to keep you upright so it can kind of avulse away a little bit of bone here. Then the Peroneus longus tendon, they work in concert. They do largely the same role in the hindfoot region. The longus tendon skates down under the foot and attaches medially, plantarly, but they both evert your foot or pull it to the side. And these two tendons really take on overload when the ligaments in here, I'll look on this side, this is the ATFL, the weakest ligament in the ankle, and the one that prevents this like anterior subluxation, and that's the CFL. All right, and then here's the bone. So three things keep your ankle steady: bone, which is static; ligament, static, they don't give so much; and then tendons, dynamic. All right, so when we have your physical exam, two things. Now, not everyone will do this. I do it because this is my, area of specialty, and this is what I'm comfortable with, and I know what I'm looking for. I always examine both sides, the uninjured leg and the injured leg. Oftentimes, I can make an assessment of how significant your injury is based on that alone, or I can just check it real quick. And I warn folks that it might, start a little bit. I say I only do it once or twice just to make sure. It's kind of like on the field when you see a knee injury and you see the trainers or the team physicians go out there, they want to just try to get that exam, the anterior drawer of the knee, to check really quickly before all the swelling gets started to see if they've torn their ACL or not, and they can put their minds at ease. It's kind of similar with my exam as well. So the anterior drawer will test this weak O ligament here. So anterior drawer ATFL, it'll pull it forward. And the Taylor tilt test, I'm going to show you a picture so you can commit this to memory. This is the anterior drawer. So grabbing the ankle, pulling you forward, okay? And this tells me that the ATFL ligament is not working well. If I can pull you forward and there's a side-to-side difference, meaning the opposite ankle doesn't demonstrate such, then we know it's a positive sign. And then this is the tilt with varus stress. So this is the ankle tilting in, and that stresses both the ATFL and the CFL ligament. This is a test for down the road, a Coleman block. You can say this patient's got some varus posturing. Sometimes when patients have a hereditary disposition for this, meaning they have this built-in mechanical varus, they have innate instability. And that's something we would look at down the road, especially if we're thinking about surgical options. Okay, so what's involved? The ankle sprain, mostly this ATFL ligament, CFL on the outer side. And what this ATFL does is restrict internal rotation and the turning in. So it keeps you from rolling in. And then this also prevents the calcaneus, the heel bone, from coming in. So we know it's more significant if you have both involved, okay? So imaging, I already mentioned that we do regular x-rays to make an assessment and generally reserve MRI imaging ultrasounds if we're worried about something more critical like peroneal tendon subluxation, retinacular tear, and we usually wait a period of time until the dust settles, if you will. Because if we didn't, I told you in the first few slides, ankle sprains and strains are so common, we would be imaging everybody unnecessarily and create increased health expenses that we don't need. So not everybody needs an R. Trust your surgeon, trust the process. We'll get it if we need it, and work from there. But so these are, like I said, this is actually an MRI scan. This is called a cross section. The front of the ankle is on top, the Achilles in this like semicircles in the back. This is the inner side of the ankle. That blue star is the outer side. And this blue star is attempting to show us where the path of the ATFL tendon is. And we don't see it. So we should see a nice black structure. We see white. That means it's been disrupted. But this is the very definition of an ankle sprain. This is what an ankle sprain looks on an MRI. We as specialists, we don't need to see what this looks like on MRI. We need to see how things get better over time and then look for more specific things. But here, these are those peroneal tendons on the outside, the brevis and the longus. Okay, so these are some x-rays, and I just put the views that we usually take. We say 3 views of the ankle, right? Often in my practice, I'll get an AP, which is the anterior posterior view of both ankles, just so I can look for symmetry, because if I see something funky that might be a congenital issue, I'll know if there's a side-to-side difference. So the anterior, the posterior, the tibia, the fibula, the talus. The mortise view shows us the relationship between the tibia and the fibula. Okay, small bone is the fibula. And then on the lateral view, we see the outline of the ankle, the subtalar joint, which is the joint below your ankle, the calcaneus. And then we can see this here called the anterior process of the calcaneus, the lateral process of the talus, and usually we can see the base of the 5th metatarsal, which on this AP view of the foot is here. So the significance of this view, this lateral view of the ankle, and the oblique view, this rotated view of the foot that makes everything look funky, is that we can see the anterior process of the calcaneus. Sometimes patients will come in and it doesn't look like it's a sprain exactly by their ankle in the typical ATL fashion, but it'll be a little bit distal, a little further away, and they'll be really sore in that sinus tarsi area of their foot where there's a muscle belly, and sometimes you can have a small avulsion fracture there. And then there's the sagittal or the lateral view of the foot. So that's the basic package, okay? For most patients who have an ankle sprain, whether it's like grade 1, 2, or 3, and we're just grading based on 1 is usually something you kind of walk off, the 2s are the 3s you can't, and the 3+ are with medial or inner ankle issues. Most of the time you can anticipate a 6 to 12 week of recovery, return to some measure of sport. Doesn't mean at the same level, doesn't mean that you're not going to go back a little weaker and or with necessity to wear sport brace or compression. We advise keeping up with the resting and icing and compression for several weeks. And then we know that therapy can assist in your overall return to balance and power. And often I will remind patients if and when they go to therapy to do the exercises on both sides, do it on the quote unquote, the good leg. So you have an understanding what it's supposed to feel like, okay? And then once again, once you're comfortable walking, whether it's in a boot or the sport brace, you're ready for some therapy. It does not have to be an extended period of time. It's what you need. It could be 1 or 2 weeks. It could be 4 or 6 weeks. It could be you do some for a while and then you just go work with your trainer and continue on your own. But this was a kind of a shocking data point that I found when I was researching this article. I did this presentation with a little bit different twist for the orthopedic residents, but one of the AOFAS articles noted up to 75% chance of arthritis in the ankle with untreated ankle sprains. So these are usually what I see are folks who have had significant sprains or strains when they were in high school or college, and then they just were not treated or undertreated, or and they went on, and now later in life they're coming in and presenting with either sequelae of that or frank arthritis. This is my general treatment plan, just general, and everybody's special, so you all get your own path. But I give people not 6 to 12 weeks, I say 3 or 4 months Most adults over 40 take that length of time. And then my breakdown is young is 25 and under. Then there's that middle ground of 25 to 40. I don't know what you call that. 40 to 80 is middle age. That's my definition. And then over 80-year-old. Okay. But so the 40 to 80, 3 or 4 months to recover. Bracing and taping do not create dependency. If there's any physical therapists on this call, I disagree with that. Sometimes telling patients not to do the bracing and taping. I think that you can't make your ankle weaker or stronger if you rely on that with some of your activities, because loading it alone is good rehabilitation. So some things that can happen subsequent to, hey, you feel a lot better, but you still are having pain in the front part of your ankle. Why is that? Or you're ascending, meaning going up, or descending stairs, and you're going down, you notice this pinching sensation in the front side of your ankle. And you've done all the exercises, you feel strong, you don't have a drawer or tilt with first stress. What is it? That's called functional ankle instability. It means you're having pain associated with it. It may be due to something inside your ankle, like an under evaluated osteochondral defect. What does that mean? Osteo is bone, chondral is cartilage, and D is just a really dramatic term for lesion. And all the terms that we utilize in orthopedics are kind of scary. I don't know why, but they're age old. We call it an OCD, not to be confused with obsessive compulsive disorder, but you might have an OCD or just thickened soft tissue and scarring. So sometimes I'll do a one-time cortisone shot in that anterior lateral gutter. It's outside the joint. It's not going to harm anything in the cartilage, and that can be a good turnaround. If it doesn't, then we definitely have to investigate with imaging. So now structural instability, that's where those actual structural pieces in your ankle, ATFL, CFL, are not doing their job. They're overloading the tendons. And then we start talking about reconstruction. The long-standing cable varus, the cable varus was the picture that I showed you a while ago back with a patient who had their standing on the block, the Coleman block test. So sometimes if you have this hereditary trait, you're doomed. No, you're not doomed. You're not doomed. It just makes it more complicated sometimes when we're treating it surgically, but that's kind of a little niche area as well. So boots, braces, sleeves, taping. I believe in anything that'll get you back to doing what you like to do. And for the most part, if it doesn't hurt so much, you can participate. But the issue in returning to play and returning to sport is such that you need to be able to, walk or jog. You need to be able to hop on your foot such that you're not going to burden your knee or your hip or hurt something else in the process that complicates it. So now I'll get off my soapbox. So the boots we like, the cam boot, if you're swollen, you can't walk, or you're developing equinus. What does equinus mean? So it's obviously related to horses. Equinus is plantar flexion posturing or contracture of your Achilles tendon. Everyone likes to hold their foot more with their toes down. You don't want to raise your foot all the way to neutral, toes towards your nose, neutral when you have an injury because it hurts. So if you sit around with your leg, toes just relax like that, even after a few days, starts getting tight. And some of you in this audience may be nodding your heads for having had experienced that. If you're not like oh so bad and you can walk and you don't think you need a boot, some kind of sport brace is good. And you also can get a sport brace to transition out of the boot. Compression ankle sleeves, they help. They're not necessarily a substitute for a bracer or boot, but they can be complementary. And then taping, you can learn how to do that from your therapist. Some people watch online, and that's another optional tool in recovery. These are just some pictures of boots. I'm sure you've seen folks with either. This is actually a short boot, more for ankle things. We like the taller version just because it restricts your ankle a little bit better. And then this top piece in here, sometimes you can wear the boot without it. This one doesn't have the separate piece. This is a pump for comfort. This one is a little bit heavier than this one. This is but they both serve the same purpose. They keep your ankle at neutral and they provide some rocker effect to make it easier for you to walk. These are braces. Now, many folks will ask me, well, what's the best brace? I say, well, the best brace is the one that you like, that fits on your leg, that's not too complicated, so that you can take it on and off, right? And then lastly, something that will fit in your shoe, because that's where you're going to wear this, in your sneaker. Not necessarily your sandal or anything like that, but in your sneaker. All right. So compression sleeves, this is just another example of some compression sleeves. This one on the right side of your screen is just from Dick's. I don't know what brand it is. This is one we sell in our office setting too. I like the ones that have the heel present. There's some that you can get at Walgreens and that have a space for the heel, and sometimes the skin gets kind of pinched here when you're swollen. That's just my impression of it. Okay. So this is a major, okay, this is a major inversion injury. So you know, based on your lesson today, that this footballer is going to have some ATFL probably tearing, maybe CFL tearing, probably stretch the peroneal tendons. And then when his ankle snaps back, he will likely have a issue on the inside part. This is just one image of the inside part of the ankle, where the deltoid is. This is the medial malleolus. This is where the deltoid enters. When you have a major inversion with eversion response injury, you can damage this ligament, which is significant, and this oftentimes necessitates surgical intervention, but that's not the majority of cases. That's the contra coup injury, only 3% of them. Most patients, if they're going to have something, will likely have a peroneal tendon injury. But if you're having discomfort in your ankle for more than about 3 months, this should send off a little bit of alarm for you. And then you have to evaluate. You say, well, maybe I should have done therapy. Maybe I should wear a brace. You can do those things, or come in and let somebody look at you. But most of after 3 months, we call that an ankle sprain that won't heal. And generally there's something else going on, which could include the tendon injury, like tendonitis, actual tendon tear or subluxation. Here's this OCD, osteochondral lesion, or OLT, osteochondral lesion of the talus, or syndesmotic injury, which is the high ankle sprain. So some patients will ask, do I have a high ankle sprain? Most people do not. A high ankle sprain is a very specific finding with injury to the syndesmotic ligaments between the two bones. This is a peroneal tendon injury. Now, I'll orient you. So this is the front of the ankle. This is the back. This is your Achilles tendon. This is the inside part of your ankle, and this is the outside part. So there's two peroneal tendons, the longus and the brevis, but they're supposed to sit together. So this Peroneus brevis tendon has subluxed in front of the fibula bone here. It's called peroneal tendon subluxation because the retinaculum, which houses them, has been torn. Now, this is not necessarily a immediate post-injury image. It's just a representation of it. If it were immediate, it'd probably be more swelling. You might notice some whiteness in the substance of these black ovals, which are the tendons. We talked about the osteochondral lesions, which can happen. They can also be hereditary. You can have a congenital, generally posterior medial osteochondral lesion on the inside part of your ankle. And again, that's why on screening views, sometimes we'll just get a view of both ankles to assess that. And then the high ankle sprains are excessive external rotation on a planted foot. And that's another one that can be lead to surgical consequence. There's another injury called a Mason-Uve injury, which again is a little higher level, sometimes associated with a fracture. sometimes not. And there are occasions where if we're concerned about it, we'll actually get something called a stress view in the X-ray suite to examine the relationships around the ankle so as not to miss a Mason-Move injury. So here's another MR scan. This is called the T1 weighted image. This is T2, called fat suppression. So things that are fluid filled, like blood vessels or joint fluid or cystic lesions, will light up whiter. So on this T1, we see everything looks the same until we get over here. And this is this posterior medial osteochondral lesion. So it looks like a void here. The black stripe on top is cartilage, but the only way that white fluid like this, not this swelling here, this is swelling in the bone, fluid can only get into an area like this if there's a rent in the cartilage overlying it. So there has to be a tear there. And then unlike the knee, ankle doesn't have menisci like extra shock absorbers. So these loads go boom right through. And then if they're hard enough or repetitive enough, and if you're chronically sustaining inversion injuries to your ankle on this side, bang, turning it in, bang, 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 you can create something like this. This is what a syntesmatic injury or high ankle sprain is. So remember I said the relationship between the tibia and the fibula. The black overlying the fibula here is the periosteum. Everybody has that. This is a younger person's bone, and I know that because this periosteum is very thick. In middle-aged people, 40 to 80, our periosteum is probably like a millimeter. But this lets them heal better. So what the radiologist is pointing out with the arrows is disruption or irregularity in the syndesmosis. And sometimes if we get a stress view, the ankle kind of widen here, and then we end up treating this with syndesmotic tightrope fixation. And if you guys follow professional sports, that's like I can't say his name, Tua Tagliova, Alabama, now with Miami. He had one side on the other ankle rather. So he had syndesmotic injury with some deltoid disruption, and then he got the screws across. And then here's a picture of those peroneal tendons, a little lateralized, your Achilles, the flexor hallucis longus tendon, posterior tib, FDL, anterior tib. There's going to be a test at the end, so I hope you're paying attention to all this anatomy. So here's just some of the things that I emphasize. Must examine both sides. I just think that's super important. And I tell some of the young people when they come in, just because I have a captive audience, and I remind them that they go away to school, if they're out on their own, and the doctor, just examines one, come with a shoulder, and they only examine one side, not the other. I say, listen, your internist is not going to listen just to the left side of your chest and not the right. So why would you ignore the other extremity? So make sure that someone's doing that for completion. We talked about just the early treatment, but sometimes, you're fighting a battle that you're not going to win if they're stretched out so much and you've got them as strong as possible. Then you kind of need to figure out if you're going to live with chronic brace wear or have an operation. So again, for most patients, we said 75% could get arthritis if they're not treated, okay? Up to 30% will have some recurring issue, either mechanical or functional. So functional is more painful, but no overt mechanical instability. Mechanical is they keep rolling their ankle because they've got these stretched ligaments that haven't been either adequately rehabilitated or just having some bad luck there. And then we start falling into this pattern of CAI, chronic ankle instability. So the non-operative management we discussed briefly, taping, bracing, restricted motion, trying to minimize re-injury. Proprioception is huge. And I would advocate for every one of you when we're done here, ensuing days, to try some single limb balance exercise. Stand next to the counter, stand on one leg, straight for like 10, 15, 20 seconds. Try to challenge yourself to get to 30 if it's possible. You have the counter to touch as need be. Do it with shoes on. If you can do that, and then get to the point where you're not touching the counter, that's great proprioception, so 20, 30 seconds. And then I challenge you to stand there and do a deep, slow knee bend similarly without losing your balance. Those are just two really easy exercises to do to rehab your ankle, and you can do those anywhere in your house, while you're at the microwave, brushing your teeth, watching a show. Okay, so we hope that 80% of you guys will get better if you follow instructions. Now, the surgical treatment, and this is getting a little bit more esoteric, and I'm not going to do an overwhelming amount because we could come back and do this next year. But what we want to do is restore the anatomy as closely as possible. Because what we don't want to do is tendon transfer, redirection of things such that we create different wear patterns, or, you know, like we say, rob Peter to pay Paul, injure or utilize one tendon, weaken it, and then we've got an issue with rehab, proprioception, etc. But the main results that we've seen with Brostrom procedures are really, really good. And what we utilize now are anchors, which makes it much, much easier and actually faster. And a lot of these things we can do with twilight sedation in a local block. You don't have to have general anesthesia or big tourniquet or anything. So Brostrom evolved this procedure, and I always kind of make a play on words, and I say, if I'm operating on a guy, it's a Brostrom, and if I'm operating on a woman, it's a Brostrom. So this is just a picture of what a Brostrom would look like. This is the fibula. This is, again, a cartoon of the ATFL, CFL. In the old days, like in the 80s, I'm just going to say that was the old days, we would cut and just kind of oversew them together, and then that didn't work very well. And now we use the patient's innate tissue, which is their imbricated kind of stretched out ligaments, specifically the ATFL, and we draw it up into the bone and use anchors in the bone so that the suture can be tightened in the remaining ligament, in addition to retinaculum, which is not sacrificed, it's right in the field, and pull that up nice and tight into the bone. It works out great. Small incision on the outer side of the foot, ankle region, tighten into the bone, walking after a week or so. This is internal brace, which is an additional suture tape device, and Arthritis is the primary company that makes this now. You know, after a few years, everyone can make it when the patent runs out. So this is the ankle bone itself. It's the fibula. We do that repair, and then prior to closure, we've already laid down anchors in the fibula and the talus, and then we put this suture tape over the top, and what that does is act as an additional check rein. So now that we have this technique available to us, we can get patients moving very quickly. So it's no more cast, okay? That was kind of the old way. So we get a week or so for soft tissue swelling to come down in a boot, in a splint, and then we transition to a tall boot, start walking right away, 50 to 100% weight bearing, and then at 1 month post-op, you're starting your PT, etc. You're moving all the while post-operatively up and down, but we're limiting the side to side until at least a month. All right, so that's the end of most of my show. I'm hoping to open this up to questions if you have them, and I could always scroll back to any slides if need be.
Great. Okay. Thank you very much, Dr. Ptaszek. I learned a lot. I was taking pictures of your slides as we went through, so thank you so much.
You're welcome.
We had a few questions that came in even before the presentation, and then a bunch more that came in during. So I'm going to ask you the ones that came in prior to your presentation that I didn't hear you discuss. One was, what is the connection between heel pain and plantar fasciitis? And it's kind of ankle-y, but I'm guessing you deal with that.
Right. So that's not like germane to the topic that we had a discussion.
Right, it
but
really isn't.
Heel pain can be caused by a number of things. I mean, you could have loss of the fat pad over time. You could have tightness in your Achilles tendon. Heel pain generally we refer to as some variant of plantar fasciitis. And the plantar fascia takes its origin off the base of the heel, mostly medially, or the inside part. Now you can develop heel pain if you have anterolateral ankle instability over time too, because you're not loading properly.
Got
But
it.
the most heel pain, we say, hey, at a minimum, get some heel cushions for your shoes. The cushier the better, not hard. And start working on some stretching exercises for your Achilles tendon and your fascia. You can Google those pretty easily. And then if it keeps up, then you see somebody.
Great, thank you. And speaking of shoes, we got a question that says, in general, are shoes with heels, and this is a series of 3 questions, are shoes with heels that might be skinny or chunky bad for women's feet? What is the ideal heel height for women's shoes? And are wedge heels better than flat shoes?
Okay, I'm gonna go in reverse order. So I always prefer the wedge, just because, okay, if you think about, when I see patients who have pathology, I see patients that have something wrong. So then they're asking me, what should I do to protect myself going further and still, you know, look nice and look good and feel good about myself. So the wedge is the easiest one to get back to, you know. So, but for most women, you know, we like to look nice and look a certain way, etc. Heels are fine. I mean, yeah, the skinny ones are harder to walk in, but if you have an affinity for them and you've worn them a lot and you're comfortable, there's no reason why you can't. Because, so, you know, it's just, sure, could you sprain your ankle? Well, you could sprain your ankle walking in a sneaker and trip on the step. So I think part of it's more relevant to the patient's coordination level with those, if they're good at it. Seriously, can I tell my postoperative bunion patients, they're not going to be restricted. They might wear something and they might be sore, it might hurt, but that doesn't mean you can't wear it. You just have to deal with the ramifications the next day. So does that help? Does that answer the question?
Yeah, it does help. And is there an ideal height for a woman wearing a heel?
Well, it depends how tall you are. I'm just kidding. No, I don't know. There's not necessarily ideal. It's more, you know, like, no, just what's comfortable. If you can do it, if you can walk in it, you look good. I happen to be a coordinated individual, but I can't do heels very well. So I lean towards wedges, which make it easier.
Got it. Great. And we'll transfer over to athletic shoes now. You remember back in the 80s, 70s, you had to wear in a pair of gym shoes. You know, the leather had to loosen up, etc. Nowadays, should you still need to break in an athletic shoe, or should they feel good right from the get-go?
They should feel good straight away. I mean, you might have to adjust the laces and things like that, but when you've tried them on and you walk with them, you know, well, say you buy them online, whatever, you know, you still walk around your house, go up and down the stairs, you should feel good in them straight away. There shouldn't be any necessity for breaking them in.
Great, great, thank you. And someone asks, well, and this is, again, going to be very specific, I think, but what would be the best treatment options for a completely torn lateral tendons of the foot on a 70-year-old person?
Okay, so I'm thinking they're meaning, and now it could be, am I reading this correctly? Completely torn peroneal tendons on the outside part of the ankle?
That's what I'm guessing. It says the lateral tendons of the left foot, so that would be the outside part of the ankle.
Right, so that is, you know, if it's, so 70, if you're middle age and you're active and stuff, you can do a brace. You can do that for some analgesia. This is a little harder just to like blanket that response, because you can have it's not, it's atypical to have both of the peroneal tendons torn. Most people, if they have the cavo-varus foot or that higher arch foot that I showed on a couple slides, may have the Peroneus longus tendon torn, and you can have ankle instability, but it doesn't necessarily create pain. So we have to differentiate what's painful, what isn't. So if it's painful torn tendons, that's a whole different matter. And I can't say I've encountered many who've had both completely torn. They don't usually tear like in half like you would anticipate or rip. They kind of can stretch and get wider, but they certainly can be debulked. And oftentimes what we do is a tenodesis of the Peroneus brevis and the longus tendon, so we get the best of both to work together.
Gotcha.
And then that debulks that side of the foot and also concomitantly stabilize the ankle ligaments. Age is not really a qualifier or disqualifier. It depends on, you know, what you like to do, how functional, how the rest of your health is, and that sort of thing.
Yeah, so that sounds like someone who should definitely give a call, come in and check, you know, visit you in the office so you can check him out and help him out. Great, thank you. Okay, Stephanie asks, can my 16-year-old who sprained his ankle in soccer camp 3 weeks ago wear a brace to tryouts in a week or so?
How's it? Well, can he walk now and hop and the trainer's been working on him?
Right,
So
right.
I'm sure he can. I'm sure he can. What has to happen is this, Stephanie. It's your son, right? Son.
Right,
yes?
right. It's her son.
So you have to, surely this is not his first encounter with the coaching staff. He needs to let them know, hey, I sprained my ankle, and let the trainers know what's going on so they can evaluate him in that light as well and see past it, okay? So that's one thing. So the tryout, like he may be just fine to do some of the skill training thing, but he's probably not going to be, you know, up to speed with running and scrimmaging stuff. So that's where you got to just assess what's going on. Now, if he sprained his ankle and he's comfortable with the brace, he can always wear the compression sleeve underneath too. Make sure it fits in a soccer cleat. He definitely could ice before and after. You know, you could even give him an Advil or something if he's not allergic before or after, just so it goes okay. But if he's able to, you know, like jump and hop and move, he may be able to. But also, the trainers at the surrounding schools, they'll be happy to like test him or tape him too if he's not too swollen. But they'll pick him out of the crowd if he looks kind of, you know, if it doesn't look like it's safe for him.
Great, great, thank you. She also wants to know where do you get those patented soccer cleats that you created?
Oh yeah, that's a good one. So Under Armour it's still out there. It's there. You can't buy them yet. That's the bottom line. Can't buy them yet because we've had. I don't want to be negative. Just like pilfering of our potential patent and stuff by a bigger company. So it's been bad. But there's still one day. Don't you worry. You'll get the emails.
Deal. All right. Super. Thank you. Okay. San asks, would electrical stimulation help with swelling from a sprain or tissue damage?
Yes.
Okay. And then San also asks, what about zero gravity shoes?
Look, I don't have direct knowledge of the zero gravity shoes for that, but I think that would be a little bit, it can be helpful, but down the line, not like immediately.
Okay, okay, great, thank you. All right, I'm trying to go through and find. Camille says she thought she heard that ankle steroid injections were not recommended.
Right, so you don't want to get ankle injections inside your ankle. You do not want an intra-articular injection by your cartilage. It's much the same in the knee, anywhere else. You don't want to have repetitive injection with steroid and lidocaine. The injection I was referencing is not in the joint. It's outside the joint at the level where the ATFL is in the scarring. So it's more of a trigger point injection outside the ankle. I wouldn't do it if it was unsafe or in the ankle.
Okay, thank you.
She's correct. Camille, you're correct. You're correct.
Great, thank you, I appreciate that. All right, Joseph says, my ortho doctor wants to fuse my ankle. He said a brace would probably not work. He also stated I would have limited range of motion. Any recommendations?
Well, Joseph probably has significant arthritis in his ankle if his doctor is recommending an arthrodesis or a fusion. And the rationale to have an arthrodesis or a fusion is if there's no other recourse or opportunity for a total ankle replacement, or the patient doesn't want to have that or endure such. I would estimate that if the ankle arthrodesis or fusion was suggested, that he already has some limitation of motion. And then the very definition of fusion is that it doesn't move. So yes, that would be limit his motion severely, but would probably be done to address his pain, I'm assuming, or deformity.
Gotcha. Okay.
I can't, I gotta see that one.
Yeah, exactly. That's another, you got to see them. Thank you. Okay. Violetta asks, for a basketball playing teenager that has repeated ankle injuries, and it's a young man, it sounds like, should he always wear a brace? And then I know your answer to this next question, or will it weaken the ankle? And you've already said, no, it won't weaken the ankle, but should he wear a brace when he's playing now, if he keeps
Absolutely.
repeating?
And he's probably on wear on both sides.
Ah, okay, good to know. Awesome, thank you. Okay, since this is from Rob, since 75% of untreated or undertreated ankle sprains result in arthritis, how do you treat that arthritis? And you mentioned that a little bit, I think, at the end. Maybe he didn't hear that part.
Yes, so it depends on what's, we're talking arthritis in the ankle. That depends on your age, okay, and how involved, how symptomatic you are. In general, again, we do the whole bracing scenario, sometimes semi-custom orthotic devices or braces that fit inside a shoe to limit mobility. Sometimes we'll do off-label things like PRP injection, platelet-rich protein injection. There's some other things on the market now that aren't readily utilized, but are more regenerative type of things. But the ultimate would be, potentially an ankle joint replacement if the arthritis is that significant.
Got it.
Not
Thank you.
everybody that has arthritis on X-ray has symptoms that correlate to the degree of arthritic that's seen, on film. So it's hard to just make a blanket statement about it.
Right, and of course that's the case with all of these. So Jill asks, what treatment do you usually recommend for posterior tibial tendonitis?
Right, so that's a whole different thing.
Yeah.
Posterior tib tendonitis is a talk we should give one day too.
Excellent. All right, I'll write that down.
Very common, the conservative, that's on the medial side, the inner side of the ankle. That is generally some form of arch support or bracing to keep tension off the posterior tib tendon. We make sure that the Achilles tendon is stretched out because you can have more tension or burden on the posterior tib tendon if the Achilles is tight. After a bracing and some form of therapy, physical therapy can be useful for what we call eccentric muscle training for the posterior tib tendon to get the muscles around it stronger. If that doesn't work, then we get an imaging study like an MRI scan, and the surgical options include debriding the tendon if it's painful, transferring an adjacent tendon called the FDL, and then doing some mechanical bony work like shifting the heel bone over to redirect the line of pull of the Achilles. And sometimes, depending on how flat the patient is, how loss of arch height, again, depending on the contralateral side, etc., we'll do a midfoot osteotomy. There's a lot of things. It's a lot. That's a big one.
Yeah, it sounds like another one that needs to be seen.
Yes.
All right, and the other two that are up here that that have come in during the presentation also, I can tell, are need to be seens. So I'll just close on one more. If you have a boot from a previous ankle injury, can you just use it for a while if you injure your ankle again or injure your other ankle?
Absolutely. So they're not side specific. So use it again. If you have one at home, you can use a friend's. If someone's going to lend you one, fine. Because often with a sprain, you're not immobilized for so long, you're not in a boot so long, you don't need to have multiple boots in your house taking up space in the closet.
Great, great. All right, Dr. Ptaszek, thank you so much for everything tonight. Super information.
You're welcome.
And thank you everyone who joined us this evening. And we hope to see you next time. But Dr. Ptaszek, I've written down the information about the posterior tibial tendonitis. We'll do another talk on that.
Super.
All right,
Hey, thanks everybody. Thank you for your attention. If you signed off, thank you.
Thank you very much, Dr. Ptaszek. Take care, everybody. Have a great night.